the speaker to be allowed to share her screen now, so that as soon as it is 15:15, she will get going. So our first speaker will be Dr. Ndagurwa. I've already introduced her to you. Dr. Ndagurwa is a fetal medicine fellow. We have worked with her for the past 3 years, and she has been running multiple pregnancy and placenta disorder clinics, and she will take us through the FMU protocols for managing multiple pregnancy, because it's a subject which is scarcely or sparsely addressed in our country in terms of our national protocols. But this is a field we feel will need attention, and everybody who is involved in pregnancy care, whether you are an obstetrician, a midwife, a sonographer, a radiographer, or any other professional, you need to know how multiple pregnancy should be cared properly for good outcome. So I will hand over to Dr. Ndagurwa. Thank you.
Okay. Morning, Dr. Verenga. Morning, everyone. Can you see my screen, Dr. Verenga?
Yes, Dr. Ndagurwa, we can see your screen. If you can show your face or your video, that would be great if your network allows, so that people can see you as well.
It has been disabled. If the host can enable it, yeah.
All right. So the host kindly allow panelists to share their face so that people can see them. Otherwise, you can go ahead for the sake of time, Dr. Ndagurwa. Then as soon as they allow you, you should be able to share your face.
That's okay. Thank you, Dr. Verenga, for the introduction. It's a pleasure this morning to speak to you on multiple pregnancy protocol for the fetal medicine units in Zimbabwe. As Dr. Verenga mentioned, I'm Dr. Ndagurwa. I'm a specialist obstetrician and gynecologist, and I'm currently a fellow in the fetal medicine unit. Sorry, I need to stop the share and start again. Can you see my screen, Dr. Verenga?
Your screen is clear.
Hello. Yeah.
Yeah.
Okay. Fine. So I just thought, well, we should all be reminded about why we are making a big fuss about multiple pregnancy care and everything else that Dr. Verenga has been talking about. We have to know that multiple pregnancies are sort of a common occurrence in our setting. Actually, a more an occurrence that is actually encountered more than more than what we think, and more than what is noticed in the first world countries. The good thing about our multiple pregnancies is that they are naturally occurring. Most of them are naturally occurring. So if we are looking at multiple pregnancies that occur naturally, the highest rate has been noted in the sub-Saharan African region, and at a rate of 18 per 1,000. So we also have to remember that with that high multiple pregnancy rate, we also have the highest neonatal mortality rate. And for that neonatal mortality rate, our multiple pregnancies are contributing about 15%, which is a significant figure. Also, we also have the highest under 5 mortality rate in the sub-Saharan African region, and the multiple pregnancies are contributing about 11%. So with this background, we need to understand what it has contributed to us to we are. It is basically because multiple pregnancies receive insufficient care in our setting. Most of the pregnancies are monitored in the local clinics and the district hospitals with just a peanut stethoscope and palpation. We should all know that that is insufficient care, because if there are some complications that are taking place inside the pregnancy, you won't be able to pick them. For example, if the woman is having twin-to-twin transfusion syndrome, you are not going to pick that using palpation or even a peanut stethoscope. Even a Doppler, a sonic aid cannot pick that. So that insufficient care is what has gotten us to this place where we are being recorded as contributing to, as having the highest neonatal mortality rate, the highest under 5 mortality rate, and with our multiple pregnancies contributing significant figures to those rates. In Africa, most of the guidelines on obstetrics, they have been silent, or some are still silent, on the special care that multiple pregnancy patients and their babies need. It is because of that silence that healthcare practitioners then practice without enough knowledge as to how they should manage multiple
Dr. Ndagurwa, I think we have lost you there. Are you still there? I think we lost you a little bit. The admin team try to get in touch with Dr. Ndagurwa, find out if we know she's talking, but we can't hear. Sorry about the glitch. I think Dr. Ndagurwa will come back into the meeting soonest. If need be, the team, the admin team, you could share a presentation from the office. Then Dr. Ndagurwa may present through probably another, without even to share the screen if the internet is not stable. Admin team, please, let's action that so that we don't lose time. We need to move. We are sorry for those who have just joined us. We just had an internet glitch. Our presenter, we lost her in the internet glitch, but we are hoping she's coming back soonest to continue her presentation. Admin team, we need a response from you. If you are having any challenges, well, just let us know so that if the second speaker is ready, we can probably activate the second speaker and Dr. Ndagurwa can follow through after the second speaker so that we don't lose time. Do we know if Dr. Ndagurwa will be able to continue presenting while we are sharing the screen? If we can activate that, the better. Admin team, did we manage to get hold of Dr. Ndagurwa? We want to know if she can still continue right now, or we ask the next presenter to chip in, then she will come after.
We are trying to get hold of Dr. Ndagurwa. We are failing to get hold of her.
Is Dr. Hlotshwayo ready to present? Let's activate the next speaker. Dr. Ndagurwa will probably follow after the next speaker if we can't get hold of her. We do not want to lose time. We have a packed program for the day. We are sorry to all our guests. These are some of the challenges that come with modernization, with the Internet of Things. Our internet in Africa is unreliable. It disappoints us, but we are not going to give up because we believe this is the future of learning. Learning has to be blended. That's the future of modern learning. So it's a challenge we have to embrace and soldier on with it. So let's activate the second speaker, then we can ask Dr. Ndagurwa to go to a site or to come to the office so that as soon as Dr. Hlotshwayo finishes, she can chip in. To go to a site which is, okay, she's back. All right.
Sorry, I'm back. Can you see my screen?
Yes, we can. Please proceed.
Okay. Okay, fine. So I was saying against the background that I had explained, we then established 2 multiple pregnancy clinics. These are clinics that are dedicated to scanning just multiple pregnancies, as in twins, triplets, quadruplets. Those are the multiple pregnancies that we have scanned so far. And we are able even to scan higher order multiple pregnancies. These clinics, we have one at Salim Mugabe Hospital and one clinic at Paride Nyatwa group of hospitals, and they run for 1 working day per week. They are manned by fetal medicine midwives, specialist obstetricians, and our fetal medicine specialist with Dr. Verenga. So I've already mentioned that we have 2 clinics per week, and we see those multiple pregnancies that are referred from both the public and the private sectors. For the management of multiple pregnancies, there are 2 important factors that I should highlight before going any further. We need to understand that determination of the gestational age is very important. This should be done timely and preferably in the first trimester, where we are able to see all the fetuses and the placental masses, so that we can also assign chorionicity at that time. Determination of gestational age is important because that's what is going to determine what we are going to do at what point. And this includes even when we are going to deliver the pregnancy, when we should give antenatal steroids, when we should give all sorts of things. So it is that important. And when you are referring a patient, make sure you refer them on time, and especially in the first trimester. If they present at your clinic or at your working place in the first trimester, don't say you have come too early. It's the best time for you at least to see something about that pregnancy. And if you are able to refer them to the next level of care, then you have to do it. Chorionicity is the most important determinant factor of everything about multiple pregnancies. It helps us to plan what we are going to do for that particular pregnancy, as in the surveillance. It helps us to plan when we'll be seeing the woman. Are we going to be seeing them every 2 weeks or every 4 weeks? The complications that we should anticipate. For example, if it's a monochorionic pregnancy, you can then start to think, or you can actually screen for twin-to-twin transfusion syndrome and other complications that are peculiar for monochorionic pregnancies. It is also the determinant factor of the outcomes that you are going to have for that multiple pregnancy and the possible morbidity and mortality that can actually take place in that pregnancy. And we have to keep at the back of our minds that monochorionicity has the worst morbidity and mortality of all the multiple pregnancies. So in our units, we start following up multiple pregnancies from the first trimester around 12 weeks. But if they are able to come at any time from 11+0 to 13 weeks plus 6 days, that is also okay. At that point, we perform a detailed ultrasound scan. This scan is done transabdominally and also transvaginally. We confirm the type of gestation. Is it a twin pregnancy? Is it a triplet, quadruplet, or whatever it is? We confirm viability of all the fetuses and the pregnancy location as well. And then we assign the chorionicity. For the chorionicity, we can count the number of placental masses if all the placental masses are visible. But if there is one placental mass, we use the T or lambda sign to say this is monochorionic or dichorionic. I'll cover that in the next slide. We also label the fetuses because we don't want to cross-scan them. So we label them, and for the methods that we use mainly the fetal positions. For the fetus who is on the right-hand side of the mother, we label them as twin 1 or triplet 1 or quad 1. And then the one who is on the left side of the mother becomes twin 2. And then if one is on top of the other, the one who is closest to the cervix or in the lower segment becomes twin 1 or triplet 1 or whatever the case. And then we can, if labeling using the fetal position is difficult, we can also use the gender. If the genders are different, if there's a boy and a girl, then we can label them as such and follow them up as such. We can also use the placental location. For example, in quadruplet pregnancies, it may be difficult to say left, right, or upper or lower segment. So we can use the placental location and or even the level of the condensation on the placental mass. We go out of our way to label the fetuses like this because we don't want to cross-scan them. We want to monitor twin 1 as twin 1 up until delivery. And then we want to monitor whatever twin or triplet as such up until delivery. We don't want to scan the abdomen of that one and then go on to scan the head of that one and come up with the fetal weight. So labeling them helps us to follow up each baby as it is up until delivery. In the same sitting, we screen for aneuploidies, trisomy 13, 18, and 21, and also Turner syndrome. We also check for major fetal abnormalities like holoprosencephaly, anencephaly, gastroschisis, esomphalos, all such things that are very important. We use the uterine artery Doppler studies to screen for preeclampsia, and if they screen positive, we commence them on aspirin 150 milligrams once daily until 36 weeks or at a point of delivery if they happen to deliver preterm. We also just check for adnexal masses like ovarian cysts and uterine fibroids as well. So I'll just go back to determination of chorionicity because it is the most important determinant factor of whatever that we are going to do. So everyone should understand how we do it. So you can see in the first image here, we have two distinct placental masses, one in the anterior segment, this one, and another one in the posterior segment. So we can easily label that pregnancy as dichorionic. We are only able to do this if you send the patients in the first trimester or at the earliest point when you have seen them. if you send them later on in the second and third trimesters, it will be very difficult to assign chorionicity. So if there is one placental mass, like what is shown in this image, and there is a thin intertwin membrane here, if the amniotic membrane is very thin and looks like a T, like what is illustrated here by the red arrow, we label the pregnancy as monochorionic. If there is one placental mass and there is a thick intertwin membrane, and then and there's a thick intertwin membrane like what is shown here and demonstrated by the red arrow, we label that pregnancy as dichorionic. So after the first trimester scan, we then go on to say, to classify the pregnancies into twins, triplets, quadruplets, or whatever order that we will be having at that point. For the twins, we can have monochorionic, dichorionic, or conjoined twins. The monochorionic can be further classified into diamniotic or monoamniotic. For the triplets, they can be trichorionic, triamniotic, meaning to say we have 3 placental masses and 3 amniotic sacs. We can have 2 placental masses, which will be a dichorionic, triamniotic pregnancy. We can also have a monochorionic triplet pregnancy, whereby we have 1 placental mass and different relationships on the amniotic sacs. However, this is very rare. On the quadruplet pregnancy, we can have a quadrachorionic, quadramniotic, meaning to say we have 4 placental masses and 4 different amniotic sacs. We can have 3 placental masses, which will be a trichorionic, quadramniotic pregnancy. We can have 2 placental masses, which will be a dichorionic pregnancy. And on the dichorionic, we can have 2 fetuses on each placenta with whatever amniotic sac relationship that they'll be having. So these are the different types of multiple pregnancies that we can see, and each one is managed according to the order. Is it a triplet pregnancy? Is it a quadruplet pregnancy? And also according to the chorionicity, because even if it's a triplet pregnancy and there is a monochorionic relationship on 2 of the babies, we can actually have twin-to-twin transfusion syndrome. We can, in that case, it will be fetal transfusion at that placental mass. So it's important to establish the chorionicity so that you can anticipate the complications that you can face for that particular pregnancy that you will be monitoring. So now we will look at the monochorionic pregnancies. We will start off by looking at twins, and we'll look at monochorionic twins. After the 12-week scan, we start following them up from 16 weeks. We start at 16 weeks because twin-to-twin transfusion syndrome can actually start developing from around 16 weeks. So we see them every 2 weeks, and at each visit we'll be assessing the fetal growth, whereby we check the biometric measurements, the head circumference, abdominal circumference, and the femur length and of all the babies. And then we also assess the Doppler studies, the umbilical artery, medullary-cerebral artery, and ductus venosus. We assess the amniotic fluid in each sac, the fetal bladders for each fetus, and we also measure the cervical length to screen for preterm labor. For the cervical length, we perform a transvaginal scan. At 18 to 22 weeks, we perform a detailed fetal anomaly scan because we know that congenital malformations are more common in multiple pregnancies, and especially in the monochorionic type. If we have diagnosed twin-to-twin transfusion syndrome, we also perform fetal echocardiography. for the timing of delivery, if it's a monochorionic, dichorionic pregnancy, which is uncomplicated, we recommend delivery at around 36 to 37 weeks. If it's a monochorionic, monoamniotic, we recommend delivery at around 32 to 34 weeks. The monochorionic, monoamniotic type is very rare, and even in our setting, I think so far we've managed less than 5 sets of monochorionic, monoamniotic pregnancies in the about 600 multiple pregnancies that we have scanned so far. The most common complications that we see include twin-to-twin transfusion syndrome, twin anemia, polycythemia sequence, selective fetal growth restriction, single intrauterine fetal demise, preterm labor, and twin reversal arterial perfusion sequence. So for the monochorionic pregnancies, when scanning them, we scan them like as if we are scanning one fetus. So we scan them at the same time. If we are assessing the head, we assess the head for twin 1, and then we go on to assess the head for twin 2. So we put the measurements on the same window, like what is shown in this image on my right side, on the right side of the screen. So let's say this is for twin 1 and this is for twin 2. You can actually see that the abdomen for twin 1 is bigger than that for twin 2. So we fly them at the same, on the same window at the same time, so that we can actually compare them real time and see the differences in growth as we scan. So after doing the biometric measurements, the head circumference, abdominal circumference, and femur length, we come up with the estimated fetal weight, and then we calculate the discordance between the two babies. We subtract the weight of the smaller twin from the weight of the bigger twin, and then we calculate a percentage from that figure. If that percentage, so that percentage is the estimated fetal weight discordancy. And if it's more than 25%, then there is a significant discrepancy in the growth of the two babies. And we label as twin-to-twin transfusion syndrome or selective fetal growth restriction, depending on the other features that will be present in that pregnancy. We assess the amniotic fluid volume at the same time, like what is shown in this image, and we'll be comparing the amniotic fluid from twin 1, from the sec for twin 1, and from the sec of twin 2. And we subtract the smaller value from the bigger value, and that difference is the discordancy. And if it's more than 6 centimeters, then there is a significant difference in the amniotic fluid volumes of the two babies, and we can diagnose twin-to-twin transfusion syndrome. We also look at the membrane. Is the membrane firm and floating freely? If it's folding or stuck on one of the babies, then it means there is reduced amniotic fluid in that baby. We compare the fetal bladders as well, because we know that the fetal bladder is also part of the classification for twin-to-twin transfusion syndrome. So part of the staging, sorry. So we compare the two bladders, we put them on the same window, and we compare the filling of the two bladders. Is one of the bladders empty? Is one of the bladders too full? Or are they comparable? If one of them is empty or one is big and the other one is very small, that also becomes a diagnostic factor for twin-to-twin transfusion syndrome. We also look at the fetal Doppler studies. As I mentioned earlier on, for the umbilical artery, we'll be looking at the pulsatility index and end diastolic flow. For the middle cerebral artery, we also look at the pulsatility index, the end diastolic flow, and the peak systolic velocity. we note any discrepancy in the middle cerebral artery peak systolic velocity because it is diagnostic of TAPS. We also look at the ductus venosus, the pulsatility index in the A-wave as well. So for twin-to-twin transfusion syndrome, we start screening for this condition from 16 weeks, and we repeat the screening every 2 weeks. It's like we are actively looking for twin-to-twin transfusion syndrome, doing the things that I mentioned in the previous slide. And we use the Quintero staging system for classifying and also for planning further management. Unfortunately, in our setting, we can only do conservative management where we continue monitoring growth and the Doppler studies. But we can do serial amnio reduction where we tap about 1 to 2 liters per session. This is in pregnancies that are at least stage 1, twin-to-twin transfusion syndrome, stage 1, and are more than 26 weeks gestational age. In other centers, they offer laser ablation, septostomy, and cord coagulation. But for us, this is not yet available. In this diagram, I'm just showing what will be happening for us to end up having twin-to-twin transfusion syndrome, where we have at some point in the placenta, we have an artery and a vein from an artery from say twin 1 and a vein from twin 2. They are in close proximity, and because of the differences in the pressure gradients, we end up having blood flowing from the artery to the vein, at the same time transfusing the twin that will be sending blood is like transfusing the other twin who does not need that blood anyway. So we end up having one twin who is hypovolemic and the other one who is hypervolemic, and that's what we'll be following up using the growth, the amniotic fluid assessment, the fetal bladder filling, and the Doppler studies as well. And we are able to pick if there is transfusion at some point in the placenta, we are able to pick that using those assessments that I explained earlier on. And then I'll move on to selective fetal growth restriction. We are still talking about monochorionic pregnancies. For selective fetal growth restriction, we need to understand the differences between a selective fetal growth restriction and twin-to-twin transfusion syndrome. For selective fetal growth restriction, we have one placental mass, and one of the cords from say twin 1 has implanted at an area that will make that the vasculature of that cord to occupy at least more than 75% of the placental mass. And we have the other twin, the cord from the other twin inserting at the margin of the placenta where it will occupy, where the vasculature will occupy less than 25% of the placental mass. So we'll end up having discrepancies in the oxygen and nutrient supply to both twins. And the one who has implanted at the little corner there, here, will end up receiving reduced oxygen and nutrient supply, and they will not grow well. So if that has happened, we are able to pick that up if we are following up the fetal growth serially, like we are checking every 2 weeks, we are able to see that this baby is not growing well compared to the other. And if it's just the growth, plus or minus the Doppler studies, then we label as selective fetal growth restriction. For this condition, we don't have the differences in the amniotic fluid volumes, the differences in the fetal bladders. It is just the growth that will be showing a discrepancy. So like what I mentioned earlier on, we do measure we perform the biometric measurements. We then calculate the difference. And if there's a difference of greater or equal to 25%, then there is selective fetal growth restriction. If we perform the biometric measurements and one of the babies, the fetal weight of one of the babies falls below the 10th centile, that is also diagnostic of selective fetal growth restriction. If one of the babies has an umbilical artery pulsatility index that is above the 95th centile for that particular gestational age, it is also diagnostic of selective fetal growth restriction. Once we pick this, we follow them up every 2 weeks, performing the growth scans and the Doppler studies. And for the timing of delivery, it is determined by the gestational age of the pregnancy and also the Doppler studies of the smaller twin. If everything is okay and we've managed to push the pregnancy beyond 34, 35 weeks, we recommend delivery at that point. However, if the smaller twin, if the Doppler studies of the smaller twin are actually worsening, we recommend delivery even before 34 to 35 weeks. Again, on monochorionic pregnancies, we can have single intrauterine fetal demise, whereby one of the babies has demised at whatever gestational age. For the patients that we have followed up so far with monochorionic pregnancy and single intrauterine fetal demise, the survivor, the Doppler studies of the survivor tend to deteriorate faster compared to what we note in dichorionic pregnancies. So for this one, the outcomes depend at the gestational age where this insult has taken place. If it's a severely preterm pregnancy, we are most likely going to lose both babies. If it's an advanced pregnancy, in most of the times we are able to save, we are able to assist the survivor and they are delivered safely by cesarean section. So what we do is, once we pick that one of the babies has demised, we perform weekly Doppler studies on the survivor until a point where we think that they have stabilized. Once they have stabilized, we start following them up to every 2 weeks, assessing the growth and Doppler studies as well. In other centers, they are able to do MRI scan of the central nervous system of the survivor. But for us right now, we are just relying on ultrasound scanning. So we advise delivery once we have pushed the pregnancy beyond 34 to 35 weeks, or we have noted that the Doppler studies of the surviving twin are actually worsening. This is if the pregnancy has gone beyond 28 weeks. We have other fetal transfusion disorders that can take place in monochorionic pregnancies, and we can have TEPS, which is twin anemia, polycythemia sequence, and the TREP sequence. I'm not going to go into details on these two in the interest of time, but we just have to remember that for TEPS, we are having small arteriovenous anastomosis, which are deeply seated in the placental mass. These are very small vessels with a diameter that does not exceed 1 millimeter. So because of this anastomosis, we have slow transfusion of blood from the donor twin to the recipient, and you end up having discrepancies in the hemoglobin count. However, we do not notice any amniotic fluid volume discrepancies because there are no problems with volume. Rather, the problems are to do with the hemoglobin count. So we are able to pick this on ultrasound scan by using the mid-cerebral artery peak systolic velocity. What happens is that in the donor twin who is anemic, they will have a high peak systolic velocity, and the recipient will have a sluggish flow of blood and a low peak systolic velocity. So we measure the Doppler, we perform the middle cerebral artery Doppler studies, and then we check on the nomogram. If one of the twins has a high peak systolic velocity and the other one has a low peak systolic velocity, that is diagnostic of TEPS. If this goes unmonitored, we can actually end up having a hydropic fetus, and one of the babies can actually die, and we end up having single intrauterine fetal demise. TEPS is staged using the Leiden system, which is just a modification of the Quintero staging system for twin-to-twin transfusion syndrome. In our setting, we are just managing these pregnancies conservatively, and we advise preterm delivery where it's indicated. Where we are able to push the pregnancy beyond 34 to 35 weeks, we then advise delivery at that point. In other centers, they are able to perform fetoscopic laser and fetal blood transfusion, and we hope in the future we'll be able to do this as well. For the TREP sequence, we have a pump twin who is supplying blood for both twins, and this twin tends to develop normally. And then we have an cardiac twin, and this one lacks a heart, and either there's no heart or the heart has been poorly developed. And in most of the cases, the upper part of the torso and the head and the limbs are also not visible. So on ultrasound scan, if you notice a mass and a baby, you need to refer that patient for to a higher level of care, because most likely it will be a monochorionic pregnancy with a TREP sequence. So when such pregnancies come to our unit, we manage conservatively because that's what we are able to do at the moment. We just continue with the fetal growth assessments, Doppler studies, and then if we are able to push the pregnancy to 34 to 35 weeks, then we advise delivery at that point. In other centers, they advocate for diagnosis in the first trimester. Once diagnosis is made in the first trimester, they are able to perform ablative techniques on the aberrant blood vessels that will be sending blood from the pump twin to the cardiac twin. They are also able to perform radiofrequency ablation and cord occlusion. So those are the methods that they use to occlude the blood vessels, the communicating blood vessels, and stop the communication and let the normal twin develop as a singleton pregnancy. Okay, so I'll move on to dichorionic twins. This is these twins, we refer them as the sort of good type of twins, because we see that the outcomes for these twins are actually very good and somehow comparable to that of singletons, though they are sort of the outcomes are sort of worse compared to that for singletons, but they are better compared to the monochorionic twins. Again, we see them in the first trimester, but because the complications for these twins are less, we see them again at 18 to 22 weeks. So we start from 18 to 22 weeks, we start following them up every 4 weeks, where we'll be performing the biometric measurements that I explained earlier on to come up with the estimated fetal weights, and we compare them like what we do for the monochorionic twins as well. We perform the fetal Doppler studies and the cervical length assessment. If it's an uncomplicated dichorionic pregnancy, we recommend delivery at 37 to 38 weeks. The most common complications that we see include selective fetal growth restriction, which is sort of the most common complication that we see in this type of twins. Single intrauterine fetal demise, discordance for fetal abnormalities. This is sort of more common in dichorionic twins as compared to monochorionic twins. We also see preterm labor And preeclampsia is also more common in dichorionic twins as compared to the monochorionic twins. For selective fetal growth restriction, the diagnostic criteria is the same as for the monochorionic twins, where we calculate the discordancy. If it's greater or equal to 25%, then we say there's selective fetal growth restriction. Or if there's one baby with an estimated fetal weight centile that falls below the 10th centile for that gestational age, or if there's one baby with abnormal umbilical artery Doppler studies, then we diagnose selective fetal growth restriction. We follow up such pregnancies every 2 weeks, and then we deliver them after 34 to 35 weeks, or when the Doppler studies of the smaller twin are worsening. For single intrauterine fetal demise, the outcomes for the dichorionic twins are sort of better compared to that for the monochorionic twins. For these ones, we follow them up after every week after diagnosis. Once we have noted that the survivor has stabilized, we see them every 2 weeks, where we'll be performing fetal growth scans and Doppler studies. We deliver them at around 34 to 35 weeks if there are no problems, but if there's worsening of Doppler studies in the surviving twin, we recommend delivery, preterm delivery. Sorry, my slides have just stopped moving. Let me stop the share and start again. Sorry about that. Okay, so for the mode of delivery for dichorionic twins, in our setting, we mostly recommend cesarean section. This is because we do not have electronic fetal heart rate monitoring, and we do not have enough human resources to monitor the pregnancies as they should be monitored during labor. If we remember that we need 2 different practitioners who will be checking the fetal heart rates at the same time at a point that is 10 centimeters apart, and we do not have enough human resources to do that when the patient will be in labor. So because of that, when we started, we just used to let the obstetricians decide how they are going to deliver the pregnancy. And we noted that for the dichorionic mothers, about 50% of them will go home with one baby, and especially the trailing twin will have a poor outcome. About 25% of the mothers will go home with no baby. This is at Salim Mugabe Hospital and Parinyatwa group of hospitals. So we then started recommending that at least if they are delivered by a planned cesarean section, we are able to control how things will take place during the delivery. And that has sort of improved the outcomes for multiple pregnancies at both hospitals. So historically, we have been taught that if both babies are in cephalic presentation, the mother can deliver vaginally. We also recommend that if the mother gets into labor and there are no problems with monitoring, of course she can deliver vaginally. If the leading twin is in vertex presentation, of course they can also deliver vaginally. However, if the leading twin is in breech presentation, or both are in breech presentation or transverse presentation, we recommend cesarean section, even if she comes when she is already in labor. We've had problems with mothers who presented in labor with one of the babies, the leading twin in cephalic presentation and the trailing one in transverse lie. In our setting, we do not have experienced people who will be able to manipulate and deliver the second twin properly. So in most of the cases, we ended up having the second twin with having fractures or actually losing the second twin because the midwives who will be on duty will not be able to manipulate the second twin and deliver them safely. So it is because of this reason that we just say, we mostly recommend cesarean section unless otherwise she presents in labor with both babies in cephalic presentation. So now we'll move on to the triplets and the higher order. So far in our unit, we have the highest order that we have managed is the quadruplet pregnancy. For the triplets, we've had about 8 sets so far, and most of them, they present very late in the early 30, 31, 32 weeks, thereabout. And it's actually very difficult to scan them and to manage them properly. However, if we are able to see them in the first trimester, we also do everything that we do for the twins. And then we see them every 2 weeks because they are just similar to the monochorionic pregnancies. So for the monochorionic pregnancies and all the higher order, we see them every 2 weeks, where we'll be checking the fetal weights, the Doppler studies, and assessing cervical length for preterm labor, which is more common in the higher order pregnancies. We perform a detailed second trimester scan because the congenital abnormalities are actually more common in the higher order gestations. And the complications that can be picked also include the selective fetal growth restriction, twin-to-twin transfusion syndrome, single intrauterine fetal demise, and preterm labor. We have to know that the fetal transfusion can also take place in the higher order gestations because of what I explained earlier on, that there may be a monochorionic relationship on 2 or 3 of the fetuses. For the triplets, we advise delivery at 32 to 34 weeks, and for the quadruplets, we advise delivery at 30 to 32 weeks. That will be the end of my presentation.